Hi, this is Dr. Akhtar Amin and today's topic is ptosis or blepharioptosis. So it is an abnormal low position of the upper eyelid. It may be congenital or acquired. Before going into ptosis, we should know about the anatomy because this is important in the mechanism of ptosis and also the surgical correction of ptosis. So the eyelid retraction, it is due to mainly three muscles. One is levator palpebrae superioris muscle. Here you can see levator palpebrae superioris muscle, and the epineurosis is anterior to the orbicularis. Anteriorly there is orbicularis and skin, while posteriorly there is tarsal plate. And then joint about 3 mm superior to the eyelid margin. It ends. This levator palpebrae superioris muscle supplied by cranial nerve 3 and it is about 15 mm in length. There are on both sides there are lateral horn and medial horn, and so lateral horn and medial horn, there are expansions that act as check ligaments. Surgically, the epineurosis can be approached through the skin or conjunctiva. The one is frontalis muscle, cranial nerve 7 supply, and it causes the brow ache. The other one is mular muscle, which attached to a tarsal plate. So these muscles are important for the eyelid retraction. Mular muscle can be approached transconjunctivally. Here the most important is levator palpebrae superioris because it causes 15 mm excursion and upper lid movement. So generally the age of onset of ptosis and the duration will usually distinguish congenital from acquired. The age and duration. Now, what if the history is ambiguous? Then old photography may be helpful. It is also important to inquire about the symptoms of possible underlying systemic disease, such as associated diplopia, variability of ptosis during the day, and excessive fatigue. Another important to exclude is pseudoptosis, because pseudoptosis, it is a false impression of ptosis, and it is important to exclude before proceeding for ptosis surgery and other. Pseudoptosis, there are different causes. For example, it may be due to lack of support. Now the lack of support may be due to anophthalmos. Here there is anophthalmos. It may be due to phthisis. It may be due to microphthalmos. It may be due to artificial eye. So here you can see it is due to artificial eye. And also pseudoptosis may be due to contralateral lid retraction. Here the right eye seems there is ptosis, but this is normal eye, while the left eye is abnormal and there is lid retraction in this left eye. So always compare the levels of the upper lid. This eye is normal because normally it should cover, the upper lid should cover 2 mm of the cornea. Pseudoptosis may be due to dermatochalasis, also known as baggy eyes. There is excessive skin, overhanging skin. It may be mistaken for ptosis. Pseudoptosis may be due to hypotropia, ipsilateral. So always do cover test. So cover the opposite eye. So the hypotropic eye will gain fixation and the ptosis will be disappear. So ptosis disappear when the hypotropic eye assume fixation on covering this the normal eye. There are different types of ptosis. Number one is neurogenic. It is caused by innervational defect. For example, third nerve paralysis and Horner syndrome. Here you can see due to Horner syndrome there is left ptosis due to Horner syndrome. In Horner syndrome, there will be anisocoria, which will be greater in the dark. So always check pupil and motility. In terminal paralysis, there will be mydriasis. Here you can see there is ptosis due to terminal paralysis. So always check pupil and motility. Mechanical ptosis, this is second type. It's caused by gravitational effect of a mass or scarring. Here you can see mass. Here you can see another mass such as neurofibroma. Another type is myogenic. Myogenic ptosis is caused by myopathy of the levator muscle itself or by impairment of the transmission of impulses at the neuromuscular junction. It is known as neuromyopathic. Acquired myogenic ptosis occurs in myasthenia gravis. Here you can see myasthenia gravis patient. There is neuromuscular junction, autoimmune antibodies variability. There will be fatigability and there will be weakness. Myogenic ptosis in myotonic dystrophy, which is a progressive muscle wasting and weakness and not able to relax certain muscles to using. And oculopharyngeal dystrophy, chronic progressive external ophthalmoplegia in which there is defect in the mitochondria. Another type is eponeurotic or involutional. There is a defect in the levator eponeurosis. Now measurements in ptosis patient. First one is margin reflex distance. This is the distance between the upper lid, here you can see, and the corneal reflection of a pen torch held by the examiner on which the patient fixates. Normal measurement is 4 to 5 millimeter. So if it is decreased, so then this is mild, this is moderate ptosis, while this is severe ptosis. Another measurement is palpebral fissure height. It is the distance between the upper and lower lid margins. Here you can see it is measured in the pupillary plane. The upper lid margin normally rests about 2 mm below the upper limbus, while the lower lid 1 mm above the lower limbus. This palpebral fissure height is shorter in males. It is 7 to 10 mm in males. In females, it is 8 to 12 mm. Unilateral ptosis can be quantified by comparison with the contralateral side. Another measurement is the levator function. Levator function is also known as upper lid excursion. How it is measured? It is measured by placing a thumb firmly against the patient brow. To negate why thumb is placed, to negate the action of frontalis muscle, and with the eyes in down gaze. The eyes are in down gaze and a thumb is placed. Now the patient is asked to look up as far as possible, and the amount of excursion is measured with a ruler. Levator function is graded as normal if it is 15 mm or more. It is good if it is between 12 to 14 mm. It is fair if it is between 5 and 11 mm, and it is poor if it is between 4 mm or less. Levator function is absent almost in congenital diseases, ptosis. In age related, it is usually normal. Another important thing is upper lid crease. So it is taken as the vertical distance between the lid margin. Here you can see the lid margin and the lid crease. And this is the lid crease in down gaze. The patient looks in down gaze, and the distance between the lid margin and the lid crease. In females, it is about 10 mm. In males, it is about 8 mm. Absence of the crease with congenital ptosis. It is the evidence of poor levator function. If there is high crease, if the crease is high, it suggests eponeurotic defect, usually involutional. This crease is also an important point to guide for the initial incision in some surgical procedures. This skin crease is absent. It denotes the poor levator function. Also in normal in Asian, normally in Asian the skin crease is absent. Pre-tarsals show, here you can see distance between the lid margin and the skin fold with the eyes in the primary position. What are the associated signs in ptosis? These are very important. Initially the full history is taken and the risk factors are noted. Then the pupils are examined. The pupils should be examined. Why? To exclude Horner syndrome and a subtle pupil involving Turner palsy. Pupil involving Turner palsy is an unlikely acute clinical presentation. Another important thing is increased innervation. So increased innervation may flow to the levator muscle of a unilateral ptosis, particularly in up gaze. There will be associated increased innervation to the contralateral normal levator. So there will be, the normal will be result in lid retraction. So the examiner should therefore manually elevate the proptotic lid and look for drooping of the opposite lid. If this occurs, the patient should be warned that surgical correction may induce a lower position in the opposite lid. Another important is fatigability. It is tested by asking the patient to look up without blinking for 30 to 60 seconds. Progressive drooping of one or both lids or inability to maintain up gaze, it is suggestive of myasthenia gravis. Myasthenia ptosis may show an overshoot of the upper lid on saccade from down gaze. From down gaze to the primary position. It is known as Cogan twitch sign and a hop on side gaze. So how it is tested, the Cogan twitch? The patient initially there is a patient look to a down gaze, then it is a patient is asked to look up. If there is overshoot of the upper lid, so this will be Cogan twitch. Ocular motility defects. So the motility defects, particularly of the superior rectus, it must be evaluated in patient with congenital ptosis. So if there is ipsilateral hypotropia, and the correction of that ipsilateral hypotropia may improve the degree of ptosis. So there may be sometimes hypotropia. Deficits consistent with a subtle or partial Turner paresis should be identified. Another important is jaw winking. It is identified by asking the patient to chew and move the jaw from side to side. Another one is Bell's phenomena. Here you can see in the picture, it is tested by the examiner manually hold the lids open. The examiner manually holds the lids open. Ask the patient to try to shut the eyes and observe upward and outward rotation of the globe. If there is upward and outward rotation of the globe. A weak Bell phenomena carries a variable risk of post-operative exposure keratopathy. So this is important, particularly following large levator resection and our suspension procedure. So after suspension procedure, there may be exposure keratopathy. Another is tear film. Tear film should be inspected. Why? Because a poor volume or unstable film may be worsened by ptosis surgery. It should be addressed preoperatively as far as possible. Another one is simple congenital ptosis. It results from failure of neuronal migration or development with muscular sequelae. Secondary to this, a minority of patients have a family history. Now what are the signs? There is unilateral or bilateral ptosis of variable severity. Here you can see in the pictures, and where there is variable severity in these pictures, there is absent upper lid crease and poor levator function. Here you can see the absent lid crease and poor levator function. Here you can see very poor levator function. One point which is different from the acquired cases so there is in down gaze the ptotic lid will be higher than normal. Why? Because of poor relaxation of the levator muscle. This is in contrast to the acquired ptosis. In acquired ptosis, the affected lid is either at the level or the affected lid is either lower than the normal. So following surgical correction, the lid leg and down gaze may be worsened. Another important is superior rectus weakness. Superior rectus weakness may be present because of its close embryological association with the levator. Compensatory chin elevation may be present in severe bilateral cases, and there may be refractive errors. They are common. They are more frequently responsible for amblyopia than the ptosis. Treatment should be carried out during the preschool years once accurate measurement can be obtained, but may be considered earlier in severe cases to prevent amblyopia. Usually surgery is levator resection. And there is Marcus-Gunger-Winking syndrome. About 5% of all cases of congenital ptosis are associated with Marcus-Gunger-Winking phenomena. Mostly they are unilateral. Although the exact etiology is unclear, it has been postulated that a branch of mandibular division, and this is the fifth cranial nerve. It is misdirected to the levator muscle. Mandibular division is misdirected. How it's diagnosed? There is retraction of the ptotic lid. This ptotic lid, there is retraction in conjunction with the stimulation of the ipsilateral pterygoid muscle. So by chewing, by sucking, by opening the mouth, or by contralateral jaw movement, there is retraction of the ptotic lid. There are some less common stimuli to winking include jaw protrusion, smiling, swallowing, clenching of teeth. Jaw winking does not improve with age, although patient may learn to mask it. Treatment is considered if the jaw winking or ptosis represent a significant functional or cosmetic problems, and in mild cases there with reasonable levator function. If there is 5 mm or better and there is little synkinetic movements, it may be treated with unilateral levator advancement. In moderate cases, unilateral levator disinsertion can be performed to address the synkinetic winking component, and ipsilateral frontalis suspension. Why? So that lid elevation is solely due to frontalis muscle. Bilateral surgery, bilateral levator disinsertion and bilateral bro suspension may be carried out to produce symmetrical result. So in mild cases levator advancement, in moderate cases unilateral levator disinsertion and frontalis suspension. And there is third nerve misdirection syndrome. It may be congenital but more frequently followed acquired third nerve palsy. There are bizarre movements of the upper lid accompany various eye movements. Here you can see, and ptosis may also occur following aberrant facial nerve regeneration. Treatment is by levator disinsertion or bro suspension. Another one is involutional ptosis or aponeurotic ptosis. It is an age-related condition, and it is caused by what? Dehiscence, disinsertion, or stretching of the levator aponeurosis. Stretching of the levator aponeurosis, limiting the transmission of force from the normal levator muscle to the upper lid. Due to fatigue of the mular muscle, it frequently worsens towards the end of the day, and it can sometimes be confused with ptosis secondary to myasthenia. There is a variable, usually bilateral ptosis with a high upper lid crease and a good levator function. High upper lid crease in a good levator function. High upper lid crease in a good levator function. In severe cases, the upper lid crease may be absent. The eyelid above the tarsal plate is very thin. The upper sulcus is deep. Treatment options include levator resection, advancement with reinsertion, anterior levator repair. Now treatment, surgical treatment of the ptosis. First one option, surgical option is conjunctival Mueller resection. Conjunctival, is the name indicate, there is resection of the conjunctiva along with Mueller muscle. So the excision of the Mueller muscle and the overlying conjunctiva. Here you can see in the picture. And reattachment of the resected edges. So the resected edges are reattached. Here you can see. The maximum elevation which can be achieved by this surgery is 2 to 3 millimeter. So it is used in cases of mild ptosis with good levator function up to 10 millimeter. So it includes most cases of Horner syndrome, mild congenital ptosis. Another option is levator advancement, levator resection. Now what occurs in this technique? The levator complex is shortened through either an anterior approach, the skin approach. Anterior approach is the skin approach, or posterior approach through conjunctiva. The indication of this technique include ptosis of any cause. It can be done for any cause. And there should be levator function of at least 5 millimeter. The extent of resection depend upon the severity of ptosis and the amount of levator function. The predictability of correcting height is the same whether anterior or posterior approach is used. However, the advantage of posterior approach is in the predictability of the lid contour. So first skin incision is given, then levator muscle is retracted and levator reattachment to tarsal plate. The third surgical technique is brow suspension, frontalis suspension. So it is used for severe ptosis, more than 4 mm. Very poor levator function, less than 4 mm levator function from variety of causes. The indication include ptosis associated with third nerve palsy and blephariopimosis syndrome, and following unsatisfied result from the previous levator resection. The tarsal plate is suspended from the frontalis muscle. Here you can see the tarsal plate is suspended from the frontalis muscle with a sling consisting of autologous fasciolata or non-absorbable material such as prolene or silicone. Thank you very much.